Good morning, everyone. I'd like to welcome you to the Gary and Mary West Health Institute and welcome you to our second West Health Ideas Series, where we bring together thought leaders to discuss how we can address the cost crisis in healthcare, the central mission of all of us here at West Health. My name is Nick Valeriani, and I have the distinct privilege to be the Chief Executive Officer of the West Health Institute and the Chief Executive of West Health. For those of you who are not familiar with us, West Health is an initiative combining 4 separate organizations with the shared goal of lowering healthcare costs by creating innovative, patient-centered solutions that deliver the right care at the right place at the right time. They include the West Health Institute, an applied medical research organization, the West Health Policy Center in Washington, D.C., our West Health Investment Fund, and the West Health Incubator. Now, our organization was founded 4 years ago by Gary and Mary West, successful entrepreneurs and pioneering philanthropists with a deep commitment to lowering healthcare costs in the United States. To this day, they are still our sole funders, making us truly independent and nonpartisan. The West also have a passion for supporting the wellness and independence of low-income seniors. Through their foundation and in partnership with other nonprofit organizations, they invested in senior community centers of San Diego to build the Gary and Mary West Senior Wellness Center, a state-of-the-art facility that serves more than 2,000 low-income seniors each year. Today, you'll hear more about the Senior Wellness Center and Passport to Health, a technology-enabled care coordination model that was developed right here at the Institute. It combines medical and wellness care, social services, and remote biomarker monitoring to track senior health. It is just one example of a technology the Institute is evaluating to advance senior care. Now, according to the U.S. Census Bureau, in 2050, the number of Americans aged 65 or older is projected to be 88.5 million. I'm going to mute this. Here in San Diego County, the number of seniors is expected to grow by 130% to almost 1 million people by 2030. This exponential growth of the graying of America has created an urgent need for reimagining healthcare and brings new challenges to this generation, which is why we are all here today. So without further delay, I'd like to welcome our distinguished panel of experts who will discuss how they are improving quality, increasing safety and care, as well as lowering costs in the region's at-risk seniors. So on our panel today, we have Paul Downey, President and CEO of Senior Community Centers, Dr. Richard Della Penna, Chief Medical Officer of Healthcare Provider Independent, and Dr. Zia Aga, the Acting Director of Health Services Research at the Veterans Affairs here in San Diego. They are joined by our moderator, Dr. Joe Smith, who is the Chief Medical and Scientific Officer here at West Health. So one more thing before I turn it over to Joe. The West Health team will be following the conversation on Twitter. We encourage you to do the same. Join us at West Health and hashtag WestIdea. We'll also be posting the video of this event on our website. So again, on behalf of the entire leadership team at West Health, thank you for joining us this morning, and I'm turning the session over to Dr. Joseph.
Well, I should start off by saying, we have about 50 minutes together, and that'll never do justice to the issues that challenge our graying seniors as well as our healthcare systems that help care for them. And so I'd encourage you not to think of this so much as an event, but as the beginning of a process, a kind of a conversation that's going to continue well past today. And so we're happy to participate in that conversation because clearly these are a set of challenges that are just not going to go away. And we're going to have to deal with them both collectively as well as individually. I want to start this off. we preloaded the group here with some questions so that they understand that these things are not completely out of the blue. And I'm not going to depart from that too much in order to make sure that the heart rates all stay in a normal range. But I'd ask the group, San Diego has some unique features. We're talking earlier, it's America's finest city. I'm sure it has America's finest seniors. But there are unique attributes of the population that perhaps point to specific things we can learn about the best way to take care of seniors as they age. And you each have different perspectives. And I wonder if you wouldn't share your views about what makes the San Diego aging community unique in that.
Sure. Well, I think a couple of things. I think first of all, in some respects, we're like the rest of the country. As Nick pointed out, the number of seniors that we're going to have in this country, we're going to double by the time we get to 2030, and then the oldest old will be with us beyond that. In San Diego, I think there's a couple of things that are unique. The first is the lack of income adequacy for a significant portion of the seniors. The Elder Economic Security Initiative Elder Index that was done by the UCLA Center for Health Policy Research tells us that 4 in 10 seniors in San Diego County don't have enough money for things like housing, healthcare, transportation, and food. And we could go into a whole discussion about how that relates to the federal poverty level, but that's a significant number of seniors who don't have enough money to meet basic needs. And I think the overarching issue for many of them is housing. We see at senior community centers and at the Gary and Mary West Senior Wellness Center, many of our seniors are spending 75 to 80% of their limited income for substandard housing. And that leaves literally $150, $160 for everything else, including their health care. And so that is something I think is very unique for San Diego.
On the positive side, we all talk about our weather, not today, but most days, and that actually is a great thing for people who are growing older. Physical activity, not exercise necessarily, but physical activity is probably the most powerful thing that we all can do to retain our independence and health as we grow older, and even when we're younger, obviously. And so having a climate where people can get outside and even walk pretty much year-round is a real plus, and I think that really is an add to growing older in San Diego. We don't have hills, we don't have ice, we don't have snow, and again, a huge advantage for those people who can make use of that. We also have some great facilities here in the way of health care. We have a high percentage of managed care penetration, so it's been around. The idea of care coordination, at least on the medical side conceptually, is part of the culture in California, but specifically in San Diego. And so I think as we see some of the changes that are associated with the Affordable Care Act, accountable care organizations and medical homes, et cetera, there's already a nidus of that in San Diego. We have a lot of senior health plans, senior Medicare Advantage plans. All of them are at least a 3-star rating according to CMS. Kaiser is the only one that is a 5-star rating. And we're just beginning to understand how to even rate plans and understand quality, but we have good facilities, so it's a question of access to them. It's a good deal for people who are poor, because with Medicare Advantage, at least now, and historically, there's no necessity to have a supplemental policy, which gets very expensive as you get older. If you're, again, below the poverty level, and Paul knows these rules far better than I do, yeah, you get government assistance to help with that, and going forward there'll be more people getting that assistance, but if not, it's a significant part of income. People spend a lot of money on health care that's not covered, regardless of their income level.
So you say a little bit, we've got a big military presence here, you're in the VA. Give me a perspective from the military VA footprint here in San Diego.
So the VA has 40,000-50,000 patients in San Diego. We're one of the larger VAs. When it comes to the military footprint, a lot of seniors who have trained in San Diego, once they retire, want to come back to this area. We have one of the largest homeless veteran populations for that reason, because of housing issues that you mentioned. And we're also seeing that there are seniors who are being pushed out further and further from the city just because of cost of living. So these are people who are moving out to East County, North County, further away from the city, and the VA has responded to that by creating C-Box or using telehealth to reach to these patients. For them, even the bus ride, which in San Diego is often rare, if you're living in East County, you're going to be driving, is too expensive. So we have to figure out ways to get services to them, closer to their homes. I think there's a dual pressure, with cost of living and distance. So there's both sort of the geographic disparity and income disparity that is being borne by the seniors.
Let me stay with you for a second, because an important thing to get from each of you is kind of the success stories around some of the technology that's being used for care coordination, a really trendy concept of just making sure that people are getting some form of healthcare integrated into their activities of daily living, perhaps, or when that's possible. The VA has been a bit of a leader in the application of some of this technology. Can you speak to some of that?
Sure. So, there's a few things that distinguish the VA from sort of our general healthcare model. One of them was the fact that as far as seniors go, we have almost half our population 60 and above, 60 and older. So 12.5 million veterans in 2010 are 60 and above. So for us, seniors is not a special population. They are our population. Any research we do, any clinical work we do, we are dealing with an average population of 65, 67, if you look at the spread. So everything that we developed from the ground up was designed to service that population. Another thing that the VA had, which made us successful, was the fact we had an interoperable, unified electronic health record system, which allowed us to share data. I think without that platform, it would have been very difficult to provide any outreach, telehealth, those types of services. And the third thing was we did not have the same economic pressures, model not fitting with the sort of long-term care in the community. But I think things are changing with the Accountable Care Act and all the changes that are happening, that sort of moving towards a similar model where there's an adoption of EHRs, there's going to be reimbursement for providing long-term services. So I think those are the key ingredients beyond specific technologies.
Well, thanks. Getting to the specific technologies, Paul, want to share a little bit about Independa and the approach that you guys are taking toward helping with care coordination?
Sure. Independa, first of all, is a software company. And so we aggregate and integrate a number of platforms. So as the Little Mermaid said, we have gadgets and gizmos and all of that. But we've also addressed the I want more. And the I want more is social engagement. And we do that through a unique partnership with LG Television. So we're taking a household commodity, something that seniors are in front of probably too much of the time, and turning that into a vehicle for social engagement, as well as for alerts, reminders, and a number of other features. So it's something that's easy to use, it's something they're already using, and we see that as a huge step forward in actually connecting people, because nobody really wants to be monitored, nobody really wants to be old, and have, gosh, I saw a picture of a device yesterday that tells you where the person is in the home. It's a passive falls detector, and it also gets your pulse. And it's about this big. It sits on your wrist. And not too long ago, we had a woman who was just about 100 years old who was visiting us when we were, Rory, where are you? When we were in the incubator in the Admiral. And we had a device that was made in Israel that looked very similar to that. And we showed it to her, and immediately, without missing a beat, she said, I would never wear that. So again, it's developing technology that's transparent, easy to use, and familiar. And so that's what we're doing. And so we're doing a lot of the things that other people are doing. But I think the key differentiator for us is the platform for social engagement. So lots of applications. We can go into that afterwards probably, but huge applications. And I spent 32 years with Kaiser Permanente before I joined Independa 3.5 years ago. And much of my career, I'm a geriatrician, but I worked locally here in San Diego, regionally, and then nationally for 11 years, developing programs for older people. The most important part of my experience in all of that time was when I was here in San Diego, making home visits. It was transformational. because as a healthcare professional, all of my training and career was in a medical office or in a hospital. When you get into people's homes and you see where the real action is and where they spend 99.9% of their time, then you get an understanding if your eyes are open. So Paul, I went to Potrero, to Ramona, to Vista, to Valley Center. I mean, used to know this county like the back of my hand, but it was in visiting those people that I began to really understand what it really required to try to help solve for the problem. So we can push stuff at people forever. We can develop gadgets and gizmos, but unless we really engage them, make the technology easy, we'll never be able to leverage it. So I could go on and on, but
Sure. So Paul, we've heard about the importance of going to people's homes. You deal with a population, many of whom don't have homes.
Right.
And so talk about how you integrate, the notion of providing meals, which some can't afford, and healthcare, which many can't afford, and putting that all in some rubric for the folks that you help to take care of at the senior center. How does that work?
Well, I think there's a couple things. And one is, what we try to do is pull together sort of a holistic and one-stop approach where we pull the resources together. So we have a lot of collaboration. We have 25 collaborative partners that we bring under one roof, because with our population, if somebody comes in for a meal and we notice something's going on, either medically or socially, we sort of practice, the old thing about management by walking around. We provide case management by walking around and interacting. And so it's literally taking somebody by the hand. Why don't we go chat, and we'll chat with the social worker, and you know what, we better, the nurse is here. Let me introduce you to Christine, our nurse, or Marissa, our nurse, while you have them. You can't say come back a week from Thursday at 2:30 for a 15-minute appointment and we'll take care of you. You've got to be able to provide the services with this population when you've got them. And I think the importance of technology is going to become more important in the future, because what we're going to have to do is be able to utilize a large cadre of non-medically trained personnel out there as our eyes and ears, who are able to refer and connect, electronically with people who are medically trained decisions. Example for us, we serve 500 homebound meals a day. So I have paid drivers who go in 5 days a week. They deliver 7 days worth of meals in 5 days, but they see these people. And so having those people be able to have the ability to help refer into a geriatric nurse to be able to intervene is going to be important. And I think the other side of technology is, and this is sort of for those of us in the nonprofit world, is that we really need to up our game in terms of collecting data. Historically, I think we've all said, well, we do good, that's nice, but I think having the data to be able to make decisions, particularly given the demographics that we're talking about, we're going to have to be as cost effective and be able to leverage as much as possible, or else there's no way we're going to be able to take care of 90 million people over the age of 65 in another 20 years.
We've hit on two important themes, and I'll try to take them separately. One is, it's not about the gizmo or the gadget, although there are many people in the audience, some of the people here at the Institute, who are working on bits and pieces of technology that can enable care coordination. We've heard about a spectrum of the elder population in terms of their background, their experiences, their resources. So is it fair to say that we're going to not have a one-size-fits-all solution, that we're going to really be forced to work and meet people where they are? I mean, so Paul, you're looking at a pretty diverse group, even though they're all at one end of the spectrum, they're still nonetheless diverse. Richard, you're going to people's homes and providing monitors of activities of daily living and their social interaction. And the VA is working with technology that is deployed remotely. Oftentimes folks who are so far away they don't get to visit their doctors very often. It seems as though that we're de-emphasizing any particular technology and more emphasizing an entire spectrum or a palette so we can meet everyone where they are. As we go to do that, what are the special challenges that you see?
I think what we have out there right now, we have a lot of proprietary systems, so it makes integration very difficult. So again, Independa's approach has always been to be an integrator And so we're, except for the TV, the LG TV, and for very practical reasons, we're really device agnostic. So as things evolve, we can always offer better best of a particular device or a solution. And so I think, again, one of the barriers that we face right now is, again, that people have single or two-point solutions, and it's aggregating those. So we talk about healthcare being fragmented. I think the technology space is also very, very fragmented. So the challenge is to integrate it.
I think you have to look at the diversity of the population. So a lot of our seniors, a lot of our veterans don't have Wi-Fi in their homes. So if you're going to deploy a device, it better work either through a plain old telephone system, which the VA used for the longest time, or you provide them with some sort of access to the internet. We assume that cell phone penetration is high. So if you, from a recent VA data, there's around 70% cell phone ownership in the veteran population, but only 20% smartphones or phones that can connect to the internet. So you have to take that into account. And one of the things the VA did early on was they tried to match the solution to the patient's needs. So if the patient can only receive phone calls, then we did care coordination through phone calls. If the patient can receive, data over the internet, then we use the internet. So you have to have flexibility in your approach.
If I could just add, for example, with the television, some people don't need the features on the television. We have a Samsung tablet for those who are more facile and can use that form factor. But for dementia population, how are we going to impact dementia care, memory care? Because again, of people with dementia, either early onset dementia or the more typical older age onset, is growing. It's becoming a major cause of disability and death among older people. So even there, we can deliver photographs. One of the mainstays of memory care is reminiscence therapy. So again, you say, well, how can, well, if they wander, that's easy, that's a technology solution, but there are even social engagement solutions that can reach a population of people with dementia. So agreed, the diversity is great, and the solutions have to be flexible. And that's a challenge, because you want things to be simple, but when they become flexible, it creates complexity. So you're constantly weighing those two.
And if I could piggyback on it, when we talk about flexibility, I mean, that's something that we see on a regular basis, is how you approach. I talked about case management by walking around. You really have to, we sort of all here in this room would assume if somebody is homeless and chronic diseases and whatnot, that of course they're going to want help. They're going to want to come in and give me everything you've got, and that's not the case. Dr. Kate Pettigrew, who's back here, who we work with, shared with me a story about a 63-year-old man who is a chronic alcoholic, homeless, and working with all sorts of different resources. And he had balance problems, and one of the issues was, he needed a walker. Well, he felt when he went in to get meals in in the homeless shelters, with a walker, he was a target, and apparently he had been assaulted. So we would assume, of course, a walker is a good thing, that would be helpful. His eyes, it was a big target on his back. So it's understanding where they're at and trying, having to do workarounds where it may not be ideal. And in some cases, too, you can be overly aggressive. You have to take a soft approach and work with them and build trust. And that's something that our staff at the Wellness Center focuses on, is building trust. So we don't come at them throwing everything at them the day they walk in. It's, Sam, let's get to know each other. Let's have a cup of coffee. We'll have lunch together and build a rapport, and then try to deal with some of the issues, because otherwise you'll get resistance.
It's this is all good to be reminded of the kind of human element. I mean, there's a lot of technology developers who are enamored with the promise of technology. And there's a bit of a dichotomous dialogue around seniors and their willingness to accept or integrate with technology. On one hand, there's a discussion that goes, well, the seniors really don't want to play with that new stuff. And on the other hand, as we look at the boomers turning 65 at 10,000 a day, these are folks who are impatient to have the technology that meets their needs. What would you tell the technology developers here about how they should look at an aging population with respect to their affinity for technology to play a role?
So in our research and both clinical work, we haven't met any resistance from seniors per se in terms of using technology, any more than anybody else. I would even say for most of the seniors, if the technology is plug and play and they can use it, which for most people, that's one of the basic entry requirements. If it requires you to go back and reset your router settings and firewall settings, forget it.
Yeah.
Yep. If it requires you to enter passcodes to match a Bluetooth device, forget it. If it's going to run out of battery, forget it. And that's for everybody. It's not just the seniors. So we need to come up with a model of technology which is that simple to use, reliable, you can deliver it to somebody's home without having to send a technology person or an IT guy to their house to set it up. And I think that is the challenge we are facing. We're doing a study right now where we're going to have 4 rounds of in-home therapy for psychotherapy, in-home sort of tablet device, PDA or whatever, or bring your own device. And it's a nightmare trying to set up all these devices to work interoperably and securely with our network. And that's the biggest challenge we are facing in setting up these home telemedicine video conferencing systems. So there's a lot to be done on the technology, and I think, Joe, to make things simple.
I would add, I mean, I agree that it needs to be simple, but I would say that anybody who says a senior can't use technology, that's a bum. Because we see that on a daily basis. We have a cyber cafe that is one of the most popular areas in our entire facility. But what it takes is a little bit of patience and somebody to show the senior how to do it. I mean, for us, for many of us, it's now sort of intuitive. I mean, I remember a number of years ago, I got a gift of an iPod, looked at it, and there were no instructions with it. I was expected to sort of intuitively know how to make it work, but and so it took my son to show me how to do what I needed. But seniors are kind of the same thing. That if you have somebody who's showing them how to do it and get over that initial fear of touching the mouse or touching the screen and doing something, they get into it because it's just as intuitive at 75 as it is at 15, so long as you know how to do it. Now, I think in cases when you get older and maybe dementia, again, I think having it be as simple as possible to connect. We're about to launch the Virtual Senior Center pilot project in coordination with Aging and Independent Services, and it's going to be a very simple device in people's homes, literally a simple touch screen where people will be able to interact, take classes, socialize, but the applicability for telemedicine is huge, and it doesn't require a lot of training. And I think that's the direction that we need to be able to go, because some of the most difficult population we serve are our homebound, because they're the ones that don't get the socialization that they need, and we all know the relationship of mental health to physical health. And so that's an important area in anything we do, is to make sure that we're dealing with the socialization portion.
One thing to just qualify the idea of simple technology, I think a lot of people misunderstand when we say simple. It's simple for the user. It's highly sophisticated for the developer or the software. So anything that is dead simple is actually more sophisticated on the back end. Or under the hood, it has to have more tools that allow voice interaction, gestures, or whatever, easier menu commands. So I think that's the challenge.
It's a great point to have the sophistication match and exceed the complexity so that you create ease of use.
Yeah, and I think in general, it's true of all of us, but I think it becomes more true as we get older. It's really is, what am I getting for my level of effort or investment in learning this technology or anything new? So again, if it's too hard for me to learn, I'm going to probably quickly dismiss that. So if I have to keep it charged, if I have to find it, it's not going to be useful to me. So I think that's an important characteristic to keep in mind as well.
A great segue. What am I getting for the investment? Right. So each of you, in fact, all of us, are competing in some way for resources, whether it's mind share or whether it's nonprofit dollars or whether it's customers. Demonstration of value, not virtue. I think we all appreciate the virtuous nature of making sure that our seniors do better, live longer, stay out of the hospital. But demonstration of value, proving that what we're doing is worth the bang for the buck. How do you see that as a burden? How do you look to achieve some evidence base that would give others confidence that extending what you're doing is in everyone's best interest?
I think the biggest burden is that we have this chasm between social services and healthcare system. I mean, the funding streams are entirely different. There are two different worlds. So much of healthcare is, again, facility-based, hospitals, offices. People don't live in those places, and yet people are social beings. So the geriatric paradigm is that when you look at function, independence, quality of life, it's medical care, that's part of it, but so's environment, so's your economic environment, your social network, cognitive, emotional, all of these things play a role in independence and function. So if we look at our two major streams, though, or three major streams, mental health, social services, and traditional medical care, there's huge chasms that exist in not only the funding, but also their interoperability. So that's a huge burden, because if I, in a social service area, show a return of investment, not for me necessarily, but for the healthcare system, that doesn't get me anything. Well, maybe you can speak to that.
Well, no, and I mean, that's one of the challenges is if we save sharp healthcare, a bundle of money, they may thank us, but I think it's showing broader systems. So for us as a nonprofit, I think it's not only showing our funders what I call social ROI, that their investment is creating something good in the community, even if somebody else is benefiting, or government is benefiting, being able to show with scarce government dollars to invest in what we're doing. And I think your point about, particularly in the social services world, the nonprofit world, one of the challenges that, and I'm speaking broadly, is that we have to understand the importance of data and being able to say, so what is our end game of what are we trying to accomplish? I often say, one of the things that senior community centers, we have 350 units of low-income housing, and also all those people we support in their homes. When somebody passes away in their home, that's a success. We view that as a success. I mean, it's sad, all of that, but it's a success because they didn't die in an emergency room, a hospital, or a skilled nursing facility. If you ask them, they certainly know. Who here would raise their hand and say, I want to die in a skilled nursing facility or an ER? I don't think anybody would. So we view success is by being able to keep people in their homes, and we all know that the cost of skilled nursing, hospitals, et cetera. So what we need to be able to do, though, is connect that intuitive. I mean, we're all intuitively, I think, that it's collecting the data. And I think in the nonprofit world, so often I describe that many of us are focused on our shoes as far as our vision, because we're worried about the funding for tomorrow, surviving today, and our long-term vision is surviving tomorrow. And we need to start looking down the road with all of this demographics that we talked about to be able to prove that we are providing value and being able to connect, whether it's the healthcare system to government, other places, and show that we have a true value and that we are worthy of investment, whether it's philanthropic dollars, governmental dollars, or if we're able to develop our own earned income streams because we're providing value. And certainly I think some of the opportunities out there with the dual eligibles and whatnot provide some of that.
So you touch upon a really important area, and as a researcher, I struggle with the whole cost effectiveness or the value proposition of health IT and telehealth. And it's been on the table for 10, 15 years. We've been doing this, still lacking information. And there's particular unique issues with it. One is, the traditional model of evaluating cost effectiveness for diseases is very disease-based. You have a treatment, you compare it to another treatment, you see quality of life years or whatever cost effectiveness, and you can make policy decisions based on that. And often it takes 3 to 4, 5 years. Well, if you do a 5-year RCT with a technology, by the time you're done, you probably can't even support that technology. It's not even provided anymore. You need to buy the new one. So that's a challenge. Getting long-term outcome data, which is really what's important in chronic disease. So you can show 30-day readmissions as a short-term outcome. But to show that these patients have less chronic renal failure or don't develop heart disease or don't die of strokes will take 10, 15 years of follow-up. There are still no studies that are going to that extent. So a lot of the value proposition is lacking due to those gaps in research and funding.
As difficult it is, isn't it also essential? I mean, we are going to have tough decisions to make. Resources are finite. We've got to do a good job, but we've got to in some way, push ourselves to do the most efficient job we can every time. And so how does one build into product approval or product development the notion that at the end of the day, I've got to show that I'm saving the system money versus the status quo, or that in order to build another senior center, I've got to demonstrate that the monies that we provided did actually net a better outcome, or at least the same outcome at a lower cost. Don't we have to do that? And what's required? What are the missing pieces?
Probably policy, payment, and practice, that they're not aligned. And so there are some actually very good interventions. So a lot of focus right now on this thing called transitional care. When people leave the hospital, go home, it used to be discharge meant dismissed. You're out of here. Whereas now CMS is developing penalties and rewards, but penalties for hospitals that have higher than expected, risk-adjusted, but higher than expected readmission rates. So there's now motivation for hospitals to care about what happens when people leave their door. Because in the fee-for-service, or as some people call it, fee-for-volume world, if they came back, the meter started running again. So there was no motivation really to keep the person out of the hospital. So those institutions, insurance plans like the VA, like Kaiser, like any organizations that is at risk, so it's more capitated payment, there's more motivation for them to at least look at some short-term ROI. So if I can use a proven intervention and then extend that intervention's reach through technology and its effectiveness through technology, then I can show an ROI pretty quickly. And so places like Geisinger and the VA has published some information on at least some of the chronic disease management, that there can be an ROI that's shown short-term. So I think my opinion, based on what you were saying, Dr. Khan, too, is that we have to look at more short-term ROIs and show it to the people who are at risk. Everybody looks at technology that I've met and say, gee, that's really neat stuff. But there are very few people who are going to be the innovators and the early adapters. They're going to be sort of towards the middle of the bell curve or the laggards at the other end of the bell. So that's a real challenge, too. It's the cultural acceptance by different institutions, healthcare or otherwise, of actually using, paying for, and leveraging technology. We're not going to have time to do RCTs.
Exactly.
We're not going to have time to do that. The aging tsunami is going to be over.
One of the things I think that we need to do, whether in the healthcare world, nonprofit world, is we need to be able to answer the question, so what? I serve a meal to a senior, so what? It's nice, they're not hungry, but I could take them to McDonald's and buy them a double cheeseburger, large order fries, large chocolate shake, and they wouldn't be hungry. So I need to be able to answer the question.
What have they done to you that would make you want to do that?
Right. Well, but you could argue that they're not hungry. But the question is, you need to be able to answer is, so what? We served them a meal. What happened because of the meal? And that's, I think, the bridge that particularly those of us in the nonprofit world need to make, because historically, we serve meals. That's a good thing. And congratulations, we served however many thousands of meals. We must have done good by doing all of that. But what we need to be able to do is articulate that because we served the meal, that senior is healthier. They're going to the ER less, fewer hospital days, and delaying, deferring long-term care. And we need to be able to ask that so what question on everything that we're doing. What happens because of that? And is that a cost-effective way? Because we can certainly throw a lot of money and answer, come up with really good answers to so what, but we've got to do so in a cost-effective way. And it keeps coming back to demographics. When you've got 90 million seniors, we have to be efficient or we're going to go broke.
Another thing just came to mind, a very important thing in my development in this area of technology and working with Independa. But I had the opportunity about 3 years ago to visit some communities in Europe where, again, social and medical are more aligned in the sense of budget and outcomes that people are looking for. This was in Scotland. This was a small village west of Edinburgh where for now it's about 10 years, 11 years, they've used a very simple array of primarily activity safety and some health monitoring and sensor installation. And they were able to demonstrate, they went from a pilot of about 89 people in this one town in 2002, went to 4,000 by 2010. So that's a pretty good scale. They looked at the outcomes not only in healthcare, but again in delayed placement at a higher level of care, and found very significant differences between that town and the rest of Scotland during that time period. So they did not have, again, the benefit of a randomized controlled trial, the comparison group, but as a result of that, that became national policy in Scotland within a couple of years, that every town in Scotland needs to provide this as a service. Different formulas for paying for it, either it's completely provided to people, depending on income, or for anybody, or there's some co-payment involved. But it just shows how other governments have approached this area of integrating technology with social services and medical care, and they were able to demonstrate, again, maybe not rigidly, but rigorously, the return on investment and how very quickly that led to a national policy. And I can't imagine that happening. Can't imagine.
It's sad that you can't imagine it happening here in many ways. So Paul, Nick alluded to Passport for Health, a program that you're helping to run at the Senior Center that integrates a little bit of healthcare together with the daytime senior facilities and the meal provision. Talk a little bit about that.
Well, hopefully during breakfast there was a display. Hopefully you had a chance to look at it, but it's centered around a wireless health kiosk that measures a series of biometrics, including blood pressure, weight, BMI. It's able to do eye test. It also does a general health screen that is able to be, displayed for the senior to be able to see as they're doing. It's a very simple display, and sort of back to our question of technology, seniors are able to use it. We have people officially in the Passport, and I'll talk about it in a second. We just have people who are using this machine on a regular basis coming in to check their blood pressure. So it's very simple to use, but what happens is it is wirelessly, it uploads into our Efforts to Outcome software, which is a database where we track every single thing that we do as far as the seniors are concerned, from meals to whether they go to the Tai Chi class, see a social worker, et cetera. The idea is it goes to our geriatric care coordinator, who is an advanced practice nurse, and she is able to monitor the data. And the idea is, the most fundamental level is to be able to intervene before a crisis occurs. I mean, that's really what we're trying to do. So this Passport program, we have IRB approval. We're going to have 300 people enrolled, 150 in the trial, 150 as a control group. And the idea will be to monitor them on an ongoing basis to determine what kinds of, what trends in their health, interventions that are necessary, working on regular meetings with our nurse, who will attempt to make sure they have a primary care physician, be looking at some of the social issues and bringing in a social worker if necessary to deal with all of the wraparound issues that are going on, but connect them to the resources that they need, again, before something bad occurs. We'll also have a great deal of data so that if something bad does occur, we're going to be able to share with their physician, several months worth of biometric data. They will be able to spot things. The idea, hopefully one of the goals, is to develop a simple app that, again, a non-medically trained person is going to be able to do some intake of some information and be able to give the uploading process that I talked about a few minutes ago. I think will be one of the long-term goals of it. But I think it's a very important first step in us, the leveraging that I was talking about. By using this, I mean, we're able to have one nurse right now is going to be dealing with 150 clients, patients, and be able to do so effectively because it's going to start this funneling process. And I think that's the fundamental thing that we're going to have to do regardless of what we do. And regardless of the interventions on any kind of healthcare, is we've got to figure out a way to be efficiently get information to those who are decision makers and can intervene, and utilize non-medically trained people as the funnelers and do that as efficiently as possible.
Sort of going back, there used to be something called the universal health worker. I don't know if you remember that, some of you, who could do lots of things, but then with licensing and guilds forming, only we could do this and only you could do that. And so these people who you want to engage were kind of pushed out because of licensing and so-called scope of practice. So, so many things interconnected, so much to do.
So a thing that's come up, I think everybody's used the word information, everybody's used the word coordination. The San Diego community, I think, is noteworthy in that it is a more collaborative and competitive environment. We've got folks here from the Beacon Project and the local HIE. How do we get a little bit more of working together to solve this problem? Because listening to the three of you each have examples of excellence and opportunities that you're pursuing, and yet I don't necessarily sense that we're all working yet together as much as we need to. And as I listen to the story from the HIE, the opportunity for kind of information sharing at a community level, that seems like it's adding enough. Is it, or are there other hurdles that are currently in the way? And I'd open that up. I mean, are there regulatory hurdles? Are there reimbursement hurdles? We benefit. Our benefactors have given us the opportunity to set up a policy center in DC. So we're quite interested in working at a policy level to tear down some of those obstacles that are in the way. But maybe there's some local obstacles that we can deal with an engaged community that's in the room.
I think it's maybe changing the way we look at things. And I'm glad you actually reminded me about the Beacon Project. That's one of the key parts of the passport that I neglected to mention, is that we're going to be able to have access for people in this project. If they call 911, we're going to know that and be able to intervene and do that follow-up when hopefully they're discharged shortly. So I think it's understanding what the opportunities are, but I think it's changing the prism through which all of us are looking at this, because I think there is a bit of a siloed approach. This is what we do, this is what the healthcare system does, this is what the government does. But I think embracing collaboration, I mean, that's one of the fundamental things that we've done at senior community centers and is exhibited at the Gary and Mary West Senior Wellness Center, is embracing the collaboration. As I mentioned, we have 25 collaborative partners from San Diego State to UCSD to Sharp Healthcare. Obviously, all sorts of folks from the Health Institute here are involved, but truly embracing that. I think a lot of us in the nonprofit world, have forced collaborations. If you want to get the money, you got to, and that's the wrong attitude. We have to embrace collaboration and not. If there's enough business for all of us that we don't need to compete with each other, we need to collaborate with each other and leverage the resources that each of us brings to the table. But it's going to require a mindset change, I think, across the board, which is a lot easier said than done. But I think the work that is being done here is the critical start to that, because that's the vision that Gary and Mary West have, and the Institute and the Foundation, to helpfully start moving us down that path. And I think you're going to start seeing, we're going to have to see that at the national level by default. I mean, I'm not saying they're going to be brilliant and see it for the right reasons, but for the wrong reasons, they're going to have to eventually get to there.
Yeah, I think there are tons of opportunities. So the VA is part of the Beacon Project. We're also part of Wheeler, exchanging health information with Kaiser, with UCSD. Both there are positive forces that are pushing us in that direction, and I think the biggest forces are patients. They no more show up to our office with printed discharge summaries and printed medical records from their other doctor. They expect us to see it online. Say, well, why can't you see my labs from Kaiser? Why should I go and get poked again today? I just had them done 6 weeks ago. We have a large, significant population of patients who go to multiple institutions. They go for their specialty care to UCSD. They get their primary care at the VA. So that's a big driver. The other is things like meaningful use, health policy change, which is forcing you to be interoperable, share information across sites. I think the issues are more than technology. I think it is a lot of administrative and legal issues. When we did our health exchange, information exchange with Kaiser, I can tell you, I won't give out numbers, but the ratio of lawyers to engineers was 4-1. For every engineer on the project, there are 4 lawyers. So, I mean, unless we can bridge that gap and get everybody to play nice.
Well, terrific. So we're nearing our time fence, and I wanted to open it up a bit for folks in the audience who had either specific contributions to make or specific questions to ask of the distinguished panel, or give us some additional items to think about as we try to take this forward. So please don't be shy.
Hello, my name is Ann Brown. I'm with the Palomar Health Foundation in North Inland County, and I'm curious: is anybody initiating something like Seniors to Senior Peace Corps? Because there are so many retirees or disabled people that could engage in meaningful volunteer work, and it seems that some of the solutions aren't based in really funding, but maybe in volunteerism.
Could I mention, have you heard about the village movement? Okay. Village movement is something that started on a different Beacon Hill in Boston is where this started, where communities that have probably a higher prevalence of older people in general come together. So Tierra Santa is got a village. There's one at Scripps Ranch, and I think one in South Bay, Paul?
I think so.
I think so. But it's volunteers. And so it's typically people who are older, maybe over 55, or in their 60s and 70s, but more fit people who are volunteering to help seniors who are less able, more vulnerable. And it's kind of paying it forward. So the idea is that when you become frail and elderly and isolated and less mobile, people will take you to the doctor, walk your dog on a rainy day. But also we envision those communities being the people who respond to alerts that technology generates, so that they will be the neighbors next door down the street who can come in and check when something happens that you don't expect to happen or don't want to happen. So that's one example.
Well, and I think that volunteering is critically important. I mean, we all need a reason to get up in the morning, and unfortunately for a lot of seniors, there isn't that compelling reason to get up in the morning. So having a meaningful volunteer experience that utilizes some of the skills and expertise, we didn't touch on, but with all the demographics of all these people hitting traditional retirement age of 65, there's a lot of talent that is retiring, theoretically moving into retirement. So we need to tap into that, both as a community, and I know AIS has their RSVP program. We have a very robust civic engagement program where we're finding meaningful volunteer activities, and underlying the word meaningful is important. But we've got to utilize those resources. But again, it's back to that mental health: is you have to have a purpose for getting up and having something to contribute back into society. So I think building more civic engagement, more meaningful volunteer. There's a whole other area of even employment. I mean, retraining older workers to stay in the workforce, maybe not working 40 hours a week, but we've got to do that. We look at our unemployment numbers today, and it looks odd to say that by 2030, we may have trouble filling jobs if everybody who hits 65 retires. So all of those things kind of go together on the mental health side of the equation.
And I'll just share with Aging and Independent Services, one of the things that we're doing right now is utilizing lay leaders, older adults, to serve as trainers for chronic disease self-management, diabetes self-management classes that are 6 weeks in length. And I think older adults want to hear and be trained by other older adults who they can relate to in terms of their disease.
Just to add to that, that intervention has shown a clear ROI, again, to the healthcare system.
You can either have none or two mics.
I'm from Eviga. We are building a mobile app for patients with chronic medical conditions. And one thing about Dr. Aga I want to ask is, you mentioned good validation that there is no resistance from seniors in using technology. And since we are building a technology app which we hope that seniors will use, but at the same time, you did mention that there are only 20% penetration of smartphones, right? And given that feature phones are almost a past, I mean, yes, they are cheaper than smartphones at this point in time, but as Android or iOS devices are getting better and better, there are cheaper options available. So I'm assuming that there will be a lot of penetration of smartphones too. And question is, are you seeing the same? And is there a play of mobile apps in providing care to senior as well? And Dr. Penna, so you did mention that Independent is developing apps on the tablets, but is there any plans to develop on smartphones, and if not, why?
Well, we have plans for smartphones for caregivers, Those are two sides of this. But I think for most of the people in our target market, the form factor is not right. It's too small. I mean, I'm older. I really have to take out my glasses. And my thumbs are getting thicker. It's just not the easiest form factor for me to use. And I'm pretty tech savvy and used to technology. I think the tablet, by the way, is a lockdown tablet. You can't get lost. All you have on that tablet is our app, which the senior interacts with. And so for some seniors, and it's surprising to me to see some of the people who want the tablet, but some do want the tablet. The current cohort of older people are most comfortable with the television. So I think it's important as you develop your app to see usability. Are they going to be comfortable using a smartphone?
The only reason I was thinking about the mobile phone is given that, as Dr. Aga said, it should be firstly simple and reliable and should be networked in the sense that if it is standalone, to make any connection with the provider is going to be tough. If it's on a phone, that you can use the phone features itself to make a call or use the internet features built within, it's much easier that way.
Right. By the way, Jitterbug, local companies come out with a smartphone. I saw it advertised. I've not seen it, so I don't know how easy that's to use, but their basic phone is incredibly easy to use.
A lot of the work, if you look at the literature and things that have worked, have actually been more standalone devices. And the reason is they're easier to use to serve one purpose. If you look at the old Health Buddy, it looks like a toaster with a screen on it. All right, no offense, but it's very effective. It's that simple to use. So you have to weigh those advantages of having a smartphone with multiple functions and being mobile, which all of us cherish, versus having a device. This is what I can touch this red button to call my doctor. And here's the screen that I'm going to get the prompt on, and not confuse it with anything else. So there is this trade-off that you have to consider when developing tools for in-home care.
One last question, and then we'll free up the audience.
A lot about the collaboration, trying to get the health services and the social services and mental health. And if you look at technologies, is there any collaboration that is going to be able to have a device in the home, and that senior or their caregiver is going to have resources to find out what is in the community? So I think that's a challenge for a lot of seniors. They're eligible for some of the high-touch human capital type resources, but there's so many actually in San Diego, they don't know what they're eligible for.
So you're right. I think getting all this, we focus a lot on technology, but really what's needed is system redesign, which what the VA started doing. We developed these, what we call patient-centered care teams, PAC teams. If you look at what's in the team, each team has a physician, a social worker, a clinical pharmacist, an LVN, and an RN. And it's the job of the social worker to help coordinate all the services from whether it's in the community, whether through the VA. I think we need to move towards the sort of holistic model of care where you have social services, people who can help find jobs, find even transportation for the patient as part of the healthcare team.
Dr. Khan, I also read recently that there's a trial going on at the VA with iPads given to caregivers to essentially provide them with the resources that you're talking about. So very practical tips about how to deal with a particular problem in say somebody with Alzheimer's disease, but also a portal to services that are available in your community.
And I think if I could jump in, I mean, I think a lot of the resources are here. It's that people don't know about them, and there's not an easy way to find out about them. I mean, if I had, magic wand or was king for a day, I would say, in high school there ought to be a class about, caregiving. I remember back when I was in high school, I had to take shop and things like that. But if you think about it, the young people, someone who's 20 years old, 25 years old, that person is going to be that sandwich generation in 2030, 2035 with kids and older relatives and understanding the resources. I mean, we deal with low-income seniors who come to us and have no family support. But I can also tell you, we get a lot of calls from people who are donors, who are wealthy, educated, and suddenly grandma has some problems, and they have absolutely no idea what to do when grandma has been discharged from the hospital and all of these things are going on. And there are resources out there to deal with it, but figuring out a way to coordinate it, an easy way, but also I think just educating our population about these issues, because I don't care how old you are, if you were born, whatever, the royal baby born a couple days ago, may not have to worry about it, but any other kid born a couple days ago, this will be with them for their entire life, at least until 2050 and beyond.
Well, thanks to the audience and thanks to our speakers for making today a success. As I pointed out, this is, while this is an event, it is part of a process. We're not going to solve this today, but hopefully we can encourage some of the information sharing and the collaboration and the coordination that we've talked about by events like this and the follow-on. Twitter, there's a lot of that going on today. That's just another vehicle for continuing the conversation. So I'd ask you to thank our panel for giving up some of their day today.